Hiya, we're Greater Manchester Doulas, and we're doing a video today about decision making in labour, pregnancy, and birth.
Mary Cronk said women do the allowing. It's your body, your baby, and your choice. But how do you decide what you want in pregnancy and birth? So, within decision making, it is really important to consider consent and to consider what consent really means because so often decisions are made for women or maybe with women, and interventions are carried out not necessarily with the woman's consent. So we wanted to explore exactly what consent means. So for consent to be valid, it must be voluntary and informed, and the person who's consenting must have the capacity to make that decision. So we're going to explore a little bit more about what all those terms mean.
So consent must be voluntary, which means that the decision to either consent or not to consent to treatment must be made by the person, and must not be influenced by pressure from medical staff or friends or family. So a decision made under coercion is not valid consent. As an example, if you are in labour and your midwife wants to uh, do a vaginal examination or some other kind of monitoring or intervention, and she says to you, if you don't do this, your baby is going to die. That is coercion, and if you agree to something under coercion, it's not valid consent.
For consent to be valid, it must be informed. That means the person must be given all the information about what the treatment involves, including the benefits and risks, whether there are any other reasonable alternatives, and what will happen if treatment does not go ahead. This means that your midwife, obstetrician, or consultant must also be going through the benefits, risks, and alternatives with you to make sure that if you say yes, that is informed consent. So when you're making an informed decision, that is really up to you. The points that we've just shared relate to the burden being on the service provider to demonstrate that they have given you the benefits, risks, and alternatives, that they've given you balanced information so that you can make a decision. Justifying the reasons that you want to do something, it can really take the wind out of your sails. It can really, it's really you giving away your power. Yeah, of course, yeah, it's fine. Of course, you can have your home birth. Do you mind if I just ask why? As soon as you get into that position, we find ourselves defensive, we find ourselves clutching at straws, we find ourselves thinking that it's our job to educate somebody else on their role, on the law, on biology, and that's not the case. It's okay to take all of the benefits and risks they give you and decide not to use them because it just doesn't feel right, because your tea leaves said so, because Kevin the Octopus said so. It's okay to make a decision based on any reason or none.
So the person must be capable of giving consent, which means they understand the information that's been given to them and they can then use that information to make a decision. And when we're thinking about capacity, it's important to remember that a woman in labour legally is absolutely considered to have capacity unless she's fallen unconscious. Being in labour does not diminish or take away your capacity to make decisions. It's important to note as well that if a woman has capacity to make a voluntary and informed decision to consent or to refuse a particular treatment, their decision must be respected. And it must be respected if refusing treatment or care would result in their death or the death of their unborn baby. So this idea that midwives can step in because they think that you're going to die, or they can disregard your decision because they are trying to save your baby, that doesn't stand. That isn't informed consent, and that is breaking the law. In the UK, your unborn baby doesn't have any rights until they're born. So it is absolutely up to the woman to make decisions for what's best for their baby.
We have often hear the phrase shared decision making being used by midwives or consultants, and it's the idea that you have to come to an agreed decision with those people. But that is not the case. All of the decisions in your pregnancy and your birth are down to you and only you. No one else gets to have a say in your decision making. So it's not shared and it shouldn't be shared. You don't have to compromise on any of your decisions to please anyone else, whether that's a medical professional or family members or partners. You don't have to compromise on anything. This is about you and your baby.
Only you, as the mother, has to live with the consequences of your decisions. Somebody else might get sacked, possibly, but it's your baby, it's your life, and the consequences are yours to live with. So that's why the burden of responsibility to make these decisions has to fall on you. Another reason that shared decision making is a fallacy is because your end goal, the thing that you want from your labor, from your birth, from your postpartum, might not be the same as anybody else, and that's again okay, because it's you that has to live your life. Something that we hear a lot is all that matters is a healthy baby, but I think when certain people say that, what they mean is as long as your baby is alive, then your baby is okay and you're okay. But you and your baby are one. And if you are not well because you've had a difficult birth, then your baby is not going to be well. Also, the definitions can mean different things to different people. So when we think of the term natural birth, that means lots of different things to different people. Generally, it means as long as a baby comes through a vagina, then that is a natural birth, but you might not agree with that. Your definition might be different, and that's okay.
So it's really important to remember that tough decisions do not have to be made in collaboration with your healthcare professionals. You have complete and total authority over your body and over your baby. Your body is your own and you know best. A really great decision-making tool for using in both your pregnancy and in any other part of your life is what we call the BRAIN acronym. Let's use an example of deciding whether or not you want to give birth at home. So you would consider the benefits to you and your baby, and also to your healthcare providers too. So the benefit to you as a woman might be that you get to birth with the people around you that you love and that care for you. You get to birth in your own environment, and the chances of you having the birth that you want might be increased. The benefit to your baby is that they're also more likely to have a normal birth and less likely to experience newborn complications that might require medical treatment. And also the benefits to your healthcare provider. So this might be your midwife. So the benefit to your midwife might be lower resources needed in the hospital on the delivery suites or the maternity-led unit.
So we'll take another example and we'll look at induction and the risks of having an induction. So what are the risks to you? What are the risks to your baby? And if you can think of any, what are the risks to the care provider as well? For example, the risks of induction could be a more painful labour, meaning that you might want more pain relief. Thinking about the risks to your baby as well. So with an induction, it increases the risk of fetal distress. Not all risks have to be medical risks. They can be completely personal. So for example, having an induction will mean that you have to be in hospital, and that might mean that you have to be away from the rest of your family. So that's something that you can put on your risks list and weigh it up against the benefits.
Risk is so personal. We all cross the road at different times. There's risks inherent to every part of life. And Gloria LeMay says that birth is as safe as life gets. And I think birth is the only situation in life where we take the worst case scenario and we think of it as the most likely thing to happen. And that's not a good way to live life or to approach birth. If someone tells you that the risk of something doubles, ask what it doubles from and what it doubles to. Because if something doubles from 0.02 chance of happening to 0.04, yes, it has doubled, but statistically it's still a very, very low number. So if you have that information, then you can make an informed decision. And there are always alternatives to any procedure, any pathway, any prophylactic intervention. There are always alternatives. And when considering them, it's important to consider the benefits, risks, and alternatives to them as well. When you're thinking about whether there are alternatives and what the alternatives are, there is a variety of places you could find the answer. You can ask your healthcare professional, but be mindful of the kind of answers that you might get. You might not be presented with all of your options. And because it is more of a conveyor belt-like approach to maternity rather than it being completely woman-centered and individualized, a lot of advice that is given is population level, and it doesn't take into consideration individual circumstances and individual needs. So when you're considering your alternatives, ask around. It might feel like a really lonely thing to do, to step off that conveyor belt and to start looking at what's best for you. But many, many women have been there before you, and many, many women are doing that at the same time as you. It might be for different reasons. They might have different priorities to you and different needs because they're individuals. But the process of seeking information and then going back to healthcare providers with your plan is a very well-trodden path. Alternatives to birthing in the system, to getting options within the system, can be quite similar to the Starbucks secret menu. You can only ask for it if you know what it is. If you know what your options are and you know what your rights are, then you can say, hey, this is what I would like and this is how you can support me.
In our opinion, this is the most important factor to take into consideration when you're making decisions. Your intuition is your inner knowing. It's that little voice in the back of your head. It's that lump in your throat. It's that feeling in your heart. It's what is going to guide you, and it's what has kept the human race alive. Sometimes listening to your intuition can be really hard because it doesn't seem to make sense when you've been considering the benefits and the risks and the alternatives. But sometimes it doesn't have to. I think your intuition is wiser than the stuff that goes on in your thinking brain. Even if the benefits that you can think up with your logical brain don't seem to be in line with what your intuition is telling you, your intuition is likely to be right. It can feel strange to listen to our intuition because it can't be measured, it can't be monitored. There is nobody else who can validate that for us. It is about trusting ourselves, trusting our bodies, and trusting our babies. In our experience as doulas and in our own births, we see that intuition guides women in the right way long before monitors and machines do. That when something is not right, women know, and they can't always say why, and they can't always put their finger on exactly what it is, and that is intuition. And that can work the other way as well, that midwives might be telling you that something is wrong and they suspect that something might be wrong. But when you're connected to your baby and you're connected to your inner knowing, you know that everything's okay, and it's okay to trust that.
What would happen next if you do agree to the suggested intervention? What then happens as a result of that? And also what happens if you decide not to? So if you do nothing. There are definitely things to consider, especially with interventions, because they do quite often lead on to more interventions, or they come as a kind of package deal. So it's good to ask those questions as well, so that you can factor that in to your decision making.
Sometimes you might see a brain acronym with an S on the end, so brains, and that often stands for smile. This one makes us a bit angry because you shouldn't have to smile to get good care. You shouldn't have to be nice to your care providers for them to treat you with respect and respect your basic human rights. So if you don't want to smile, don't smile. You don't have to smile. You don't have to ask. This is your decision. This is your baby, your pregnancy, your birth. And the person with the most invested here is you. So it's okay if these feel like big decisions and that you don't want to smile and you don't want to make friends with people along the way. It's okay to put yourself first. I think often women don't feel it necessary to learn these tools. They don't feel it necessary to write a birth plan. And we totally get why. You know, we should be able to expect women-centered care when we go to maternity services for support. But unfortunately, that isn't the reality. So it's really important to remember that what we hope for from maternity services is not necessarily the same as what's available to us. We often hear that the system is broken and it's the system that we need to fix. But in our opinion, the system is working perfectly. Maternity services are built on a foundation that is patriarchal. It's a technocratic model of care that does not consider the holistic needs of women. So in that sense, it's working perfectly. Women who are small and broken and don't feel able to use their voice serve the patriarchy in much better ways than wild women who have birthed in their own power. So with this in mind, your doctor or your midwife isn't necessarily making suggestions and decisions in your best interests or that of your baby. And the way to know whether or not a decision or an intervention that's being suggested is right for you is to work through these tools, is to do the work on connecting with your intuition and your inner knowing, because that is what's going to guide you in this journey. It's important to remember that policies and procedures within maternity services are not always evidence-based, that those policies come out of lots of different factors, from the risk of litigation to the system, timekeeping, money. There are so many things that come into that decision that is not just what is going to lead to the best outcome for this woman and her baby. They're not individualized policies. They use population level data and information. And they are also policies and procedures for a system that is consistently overstretched and underfunded, with staff who are not working in ideal conditions. And when staff aren't well cared for, that has an impact on the care that they give, and that doesn't always serve the woman or her baby. And hospital policies and procedures are not the law. They are not rules that you necessarily have to follow. They are guidelines for healthcare professionals, not for you. So going back to the very beginning of this video, women do the allowing, and you know what's best for you and your baby.
Sometimes it would appear that risks crop up around 36 weeks, risks that were not there before. Midwife Sarah Wickham had written a lot about this, about how late-term screening tests and late-term interventions such as scans are no more than fishing expeditions, especially when a woman is planning a home birth. It would appear that all of a sudden, around term, the woman is suddenly too old or too fat, or her baby is too big or too small. These are risks that we hear all the time that were not there before. Often women fall into the trap of thinking that two very small risks add up to one bigger risk, and that is not the case. Most risks are mutually exclusive. If you have a high BMI, then maybe your risk factor is slightly elevated. If you are over the age of 40, your risk factor is elevated. But the two things, you can't add the two small risks together and end up with a bigger risk. That's not how risk works. Obviously, some conditions do impact on other conditions, but it can be medical care providers' advice that say, oh, because you have this and because you have this, then the best thing to do is this. And one, it's never their decision. Two, ask for evidence. Does that apply to you? Does that apply to you as an individual? Or is this just blanket level general population advice that doesn't actually apply to you and your situation and what you want? So we run a pool hire support scheme, and the reason that we set it up wasn't just so that women can have pools at a low cost. It's so that women could be supported, because from our experience as doulas, we know that women, sometimes they're planning home births right from the get-go. Maybe they're not listened to. They're wanting to talk with their midwife about their plans to home birth, and maybe the midwife has nodded along. Yeah, of course. Yeah, we'll just see what happens. We'll just see what happens. And then all of a sudden, at 36 weeks, she has a risk factor that wasn't present before, and her decision to give birth at home, or a decision to do something outside of the norm, is suddenly appears no longer to be on the table. And the reason that we have support as part of our Pool High scheme is so that women can come to us with, oh, I've been told I can't have my home birth now, or I've been told that I'm too high risk. I've been told I can't give birth on a midwife-led unit. I've been told that I can't have my elective cesarean. Most of the time, this is not true, and the decision is still yours to make. The reason that you made the decision in the first place is still apparent and still valid. The benefits and risks are still the same, and it's still up to you about what you want to do, even if you're told that you're not allowed, or you can't, or that you must, or that it's out of their hands because they have to do something. Like, none of that is true. Ask around, talk to other women who've made similar decisions, who've been told similar things. Don't just accept it unless it's right for you. When you're told something like this, because you've suddenly, you've turned 36 in your pregnancy, so therefore now you're higher risk, it's okay to question that. It's okay to ask for the evidence. It's okay to ask around. It's okay to access support, and apply the BRAIN acronym to absolutely everything. It doesn't necessarily need to be in response to a prophylactic measure. It can be anything, and the more you get used to applying it to things, should I have coffee or tea, should I walk to work, or should I get the bus, the more easily that comes back to you.
The decision-making tool that we've been through already is super helpful, and then the next step is implementing that decision. We often hear women asking, when do I get to talk about my plans for birth? And there is no answer for that, because it quite often just doesn't get brought up until very late in pregnancy. So know that you don't have to wait. You don't have to wait for permission to speak to your midwife about anything that's on your mind. Bring your birth plan to your appointments. Talk to your midwife about these things if you want to. You don't need to wait for them to bring it up, because that will often be very late on in pregnancy. And that's where, as Ellie said before, things do tend to crop up that become risk factors. Speaking about it earlier rather than later gives you time to really solidify plans and let them know what your plans are.
Often the first hurdle for implementing decisions is that your midwife says no. But a midwife not wanting to do something is not a no. Their experience and their skill set is not your responsibility. And as an organisation, maternity services have a responsibility to work to find someone who does have the skill set that is required to support you in the way that you need to be supported. The next step, if your midwife says no, is to look at seeing if you can speak to senior staff. So that might be the head of midwifery, it might be a consultant midwife, someone who has more seniority and more power to make decisions and agree to the things that you want. When talking to senior staff, you don't need to accept yes or no straight off. There is always someone higher up to talk to. As Ellie said earlier on, there are always hidden options that haven't been presented to you. Just bear in mind that a no doesn't mean that you can't get the support that you want. And unfortunately, a yes in these conversations doesn't always mean yes. That women have these conversations, and then when it comes to their birth, the person who's caring for them said, I didn't agree to that, or I don't think that happened, or I don't remember that conversation. So it's really, really important to get things in writing, to get a letter that is signed, that is attached to your notes, that says, this is the care plan that has been agreed for this woman. During these conversations, don't fall into the trap of proving your decisions. and explaining them. It's not your responsibility to prove that you've been informed. If you are making a decision because the stars are in alignment and your tea leaf said so, that is your right to do so. It is not your responsibility to explain the reasoning behind your decision making to your midwife, to your care providers. And take your time. You don't need to make decisions on the spot. You know, when you talk to your midwife, when you're talking with a senior member of staff, that is just another opportunity to gather information and another opportunity to get the right support in place. But it doesn't have to be a situation where you have to make a decision there and then.
We often come across women who say, I know I didn't conceive on that day. I know the date that I conceived, but they've got the dates a week ahead or a week behind. And I worry about how that's going to impact the end of my pregnancy. Cross it out and write your own date. They are your notes, and it's your pregnancy and your baby, and you know your body and your life like nobody else ever can. And the same with if you're having a home birth, and what you keep hearing back is, oh, we'll talk about that at the next point, or we'll talk about that at 37 weeks. You can just write on the top of your notes that you're giving birth at home, if that give you peace of mind, and if it would give a clear message to anybody else who would read your notes, exactly the kind of birth that you want and how you can be supported in that.
Because we find that it can happen in quite subtle ways, or ways that we don't necessarily notice straight away. So one sign that your options are being limited is when your midwife says, we'll talk about that when you're X weeks, when you're 36 weeks, we'll talk about you wanting a home birth. We don't need to discuss this now. And that delaying tactic is very much a tactic, because the more those conversations are pushed forward, the less time you have to get plans in place and to get the right support. Especially if you're making a decision that might require maternity services to find a midwife who is maybe more specialist or more experienced in your unique situation. So the earlier that you can have conversations, the better. You don't need to work to anybody else's timeline but your own.
If a midwife says to you that they've booked you in for an induction, for example, without even asking you, that is not okay, for one, but also it's a sign that should say to you that they think that they can tell you what to do, and that decision is always yours. So if someone is booking you in for something that you didn't agree to, that is limiting your options in a massive way, because it's not giving you the opportunity to accept or decline whatever it is they've booked you in for. It's not giving you the opportunity to ask the questions and get the information. So that's a massive sign that your options are being limited, and you can absolutely reject it. If you try to cancel that appointment and the response that you get is, I need a senior staff member to agree before I cancel that, this is not true, and you don't need to wait for anyone's permission to cancel an appointment.
Something you might hear is, well, you'll have to speak to the consultant about that. And that might be slightly reminiscent of when you were younger and you were sent to the head teacher's office. It's a sign that the person speaking to you recognizes that they possibly don't have the authority to get you to do the thing that they want you to do. And they also don't recognize that they don't have the power to say, no, you can't have this thing, or that you can, or that yes, you can have this thing. So often midwives like to skip that conversation themselves and hope that the consultant will have it in their place, or that the threat will be enough to get women to reconsider their choices.
Something else that we hear is when midwives or doctors say, this should be fine, or we'll just have to see about that. Again, very reminiscent of when we're younger and we want something in the shop and our mum says, we'll see about that. Or, you know, Well, yeah, we'll think about it. That should be fine. And you know that that means you're not going to get it. You know that that means that it's just placating you, and you're not a child. You are a grown woman who deserves to be treated with respect. And respect is somebody taking the time to listen to what it is that you want and what decision you want to make and what you want to talk about. So if someone tries to brush you off with a kind of non-committal response, you can push them on that, and you can make it clear that it's really important to you to talk about that now and to get something more solid in place, be that something in writing or, you know, a more formalized plan.
If you tell a midwife what your plan is and she comes back with, "Can I just ask why?" No, you don't need to explain your decisions to anyone, including your midwife. So if they're asking why, it means that they're not respecting your decision and they're trying to find loopholes to persuade you otherwise. So don't fall into the trap, as we said before, of trying to explain it or justify it. You don't need to. That's the bottom line, is that it's your decision.
The next one is, I think, the strongest form of coercion, and it has a name, and it's called playing the dead baby card. It's the strongest form of coercion there is, because we are programmed to do what is best for our babies. And as soon as somebody throws that out there, oh yeah, that's fine, but you know, your baby might die. Or when somebody exaggerates the risk of the death of a baby, then that's a form of coercion that should be stood up to, but it's very, very difficult. As doulas, it's quite easy for us to say, you know, this is the tactic that they're trying to do. But when you're on the receiving end of hearing that, I'm sure that it has a very different impact. It's hard to unring that bell once you've heard it. But if you are prepared that somebody might play the dead baby card, then when somebody does it, you can hear it for what it is. When somebody feels that they've lost control of the situation and they realize that you're making an informed decision and that it's your right to do so, that's often when the dead baby card comes out, and it can be said in such a way that the impact doesn't hit until later. Oh, that's fine. Yeah, of course you can have your home birth. You know, it's completely your decision. Obviously, your baby might die, and it's so unfair. But you know that if somebody does use it, it's because their back is up and they know that they have lost. If you do hear that, then we can go back to what Mary Cronk has advised all pregnant women get used to saying, which is, would you like to repeat what you just said to me? You can take your power back in that moment. I'm not saying you won't be shaken. It's very, very difficult to hear, but it can be counteracted, because that is a very clear form of coercion. The worst could happen at any time. You know, unfortunately, we could get hit by a bus, we could choke on our food. Disasters happen all of the time that could result in death, but we don't bring them to the forefront unless we're trying to convince the other person of a very weak argument.
This is absolutely a tactic of coercive control, to keep asking and to keep putting forward reasons why the person should say yes to you. And it's not okay. You don't need to listen to what comes after the but. The fact that you've said no, or the fact that you've made your decision, whatever that may be, should be listened to and should be respected. And that is the end of the conversation if you want it to be. This is one that often comes up during a birth, which is even more frustrating and horrible, because during labour, a woman is at her most vulnerable and she doesn't want to have to engage in these conversations necessarily. And it is, I just need to listen to your baby. I just need to do a vaginal examination. And the truth is they don't need to do anything. What they should be doing is offering, and then it's up to you to decide whether it's something that you need or not. If someone is saying that they need to do something to you or for you, that is a really clear sign that your options might be being limited, because nobody ever needs to do anything unless it's a call that you've made.
If it feels like your options are being limited, or if it feels like you have a really difficult decision to make and you want support, then it is there for you. There might be doulas who live near you. There might be doulas who live further away, but who can reach you by Zoom or by phone or other means, just as we support women who are further away than Greater Manchester. Talk to other women. Other women's stories are like medicine, and they can help us with our own stories. There are organisations such as AIMS and Birthrights who offer women-centred care and advice and support. AIMS stands for Association for Improvements in the Maternity Services, and you can contact them by phone or by email if you have something specific to talk about, such as I've been told I have to be induced because of whatever reason. It can feel, like I said before, really lonely to question what you're being told and to maybe choose something different. But they get phone calls like that every single day, and their information is accurate, it's up to date, and they're incredibly supportive with how they go about it. Birthrights come at it from a different perspective, but one that's also valuable. Let's say a woman has been told that she must have an induction because of whatever reason. You can contact Birthrights about that, and they are able to contact the hospital on your behalf and talk to them. And their angle would be, do you realise that by curtailing this woman's rights, by limiting this woman's options, that you are leaving yourself open to legal action, which is a different approach, but valuable if we want to change the maternity systems.
Doulas are a great support for women, not just at your birth and practically, but throughout your pregnancy. Having a doula can be really great for supporting you to make these decisions and supporting you to find what is right for you. We often work with women who want to critique the system, who want to challenge the system, and who are making decisions that are outside of the norm and do not necessarily fit within the box that the maternity services would like us all to fit into. So if you feel like you're trying to make decisions that don't quite fit in the box and do feel a bit out there, don't hesitate to get in touch with us, because we're always happy to help.